this is another interesting case, which was a 12-year-old boy whom we'd done a graft for earlier, penetrating keratoplasty, and the graft had failed. So the plan here was to do a PDEK, and he also had some cataractus changes. So I was also planning to do a cataract along with that. This is a type 1 big bubble which has been created, and since I'm doing it on a graft, on a PK graft, I need very exact sizes. So I've refined that period, that type 1 big bubble with it refined rather than cut it freehand as I usually do, because I want the size to be well within the to be within the margins of the graft. Now you can see that's the graft. I've removed the epithelium to allow me better visibility. I've filled it up with viscoelastic. I'm going to do the cataract surgery first. So I've made that initial cut in the neck, and I'm going to take my forceps to complete that rhexis. So in this case I alternate between forceps and the needle, and you can see that there's that iris membrane, that membrane there. I have to go with a forceps here, as I said earlier, and try to tear that rhexis. You can see that the visibility is really compromised here, so I shift to an endo illuminator, which I hold on the outside. I've seen that if I put this endo illuminator in the anterior chamber, it sometimes creates too much of sclerotic scatter and the visibility becomes worse. The visibility through the microscope actually is better than what you see through the camera. Of course, you could put it in the posterior chamber, but here I didn't want to put it in the posterior chamber because I didn't want to enter that as of yet. Now I've removed that. I've removed some of the postosinic and all, but now you see that that was actually just a fibrotic membrane on the anterior capsule, and this is the actual rhexis. So I have to actually go around. I find that I have to go around a second time. The first thing that I removed was just a fibrotic membrane, which are these surprises that you sometimes get. I then go around and do a second time a rhexis, and I'm doing the cataract extraction. It's a very soft cataract, obviously, since it's a young child. I've removed most of it, but I've got the superior rim, which is a subincisional cataract cortex, and I'm having difficulty in removing that. Now, at this point of time, somehow I feel that I should place the IOL, and I know Chitra ma'am is going to say, why didn't you go in for the bimanual irrigation aspiration? I just didn't. I thought that I would put in the intraocular lens, and I would just aspirate it later with after having the IOL as a scaffold. But then I find that I'm actually in a little bit of trouble. I tried to get it out from around the IOL. It didn't go. It didn't come. So then I went under the intraocular lens, and then the inevitable happens. So you can see there, if you look carefully, there's two linear a tear which is seen in the posterior capsule, and also that cortex has suddenly moved more posterior. So now at this stage, what I do is basically I do an optic capture. So I had the IOL in the bag already. I bring the optic out in front of the rhexis. I've got a good rhexis, so I've got a good support there. I've brought the optic out. I've done an optic capture, and I still have to go ahead and handle that dropped bit of lens matter. So I go via pars plana route, do a vitrectomy, remove that part of the dropped nucleus, and then I decide to go on to the PDEK part. Now, I've also, of course, for sake of editing, I've removed that, but we also go ahead and do a triamcinolone acetonide assisted IVTA. Now, because the iris was so dilated and fixed, I've done a pupilloplasty because you want good support for the air when you're actually doing a PDEK. I remove that chamber maintainer, that trocar cannula, and bring it into the anterior chamber. And this is the air pump assisted technique, which I find very, very beautiful, which I started after Dr. Amar had introduced the PDEK technique. I started the air pump assisted PDEK, which really makes the surgery so much more easier, and it makes it a pleasure to perform. So you can see that under air, I'm doing a decimeter rhexis. You can see all the margins of the decimus membrane. This is the EPDEK or the EDMEC technique, which also I published in JCRS. It allows you, with the help of the endoilluminator, to see even through very edematous corneas to identify the side of the graft. Even when you're putting it into the anterior chamber and visibility is poor, with just that technique, you can make out that the graft is the right way up, and you can go ahead and unfold that graft. And now, as you were doing DMEC, I don't have to make sure that it's completely perfectly centered. Instead, I can accept some amount of decentration of the graft. I inject in air. You can see it's a decentered graft, but this is the beauty of the air pump assisted PDEK. You go in through a side port and just pull it into place, and the whole graft just moves into place, which would not have been possible with a DMEC. So once I've got that, I've got the air pump going. Continuous pressurized air is being infused into the anterior chamber, and there are some folds in the periphery, which again I'll be removing with under the air. So these are the advantages of the air pump assisted technique. You can just unfold that very easily and very gently, get rid of those peripheral edge folds, and then we close up everything and replace some of the air with fluid so that you get an 80% fill. This is the post-operative appearance of that 12-year-old boy. He did really well with the stable intraocular lens, and you can see that the graft really cleared up beautifully. So just wanted to share this case where something unexpected happened, but you really have to think about what you can do in that situation and manage it in a way that you still try and get the best possible outcomes for the patient.
It goes without saying that was an amazing surgery. I'm going to ask Shreyas to ask his questions, but just before that, one very basic question. With this amount of lack of visibility, why couldn't you have done a PDEK first and then later done a cataract surgery? Because it sort of complicates things. You had a fibrous membrane over it and a fibrous capsule, and the different things which happened could have been obviated. And there was a lot more about the cornea, so I thought Shreyas should get in and...
Yeah, that's a beautiful question, ma'am. Basically, as far as possible, if I have to remove cataract also, I prefer to do it in the same sitting, because generally with the endo illuminator, you can always get a view that's good enough to finish your surgery. Now, in this case, I got stuck because instead of doing a bimanual IA, I tried to, put the lens first and then remove the cortex. But if I'd got a bimanual IA, the visibility was not the problem. Now, if I do a PDEK first and then do the cataract, I would have to space out quite a bit of time because I don't want to go immediately. And then I'm going doing intramaneuver maneuvering the graft, which would of course lead to some amount of endothelial cell loss. So I want to avoid that as much as possible. So if possible, I want to do everything in the same sitting so that after that I don't have any intraocular manipulation, which can possibly lead to a decrease in the graft cell density.
Dr. Shreyas?
I just enjoyed the case, madam. It was very nice and very well done. I'm going to show something very similar, so I have absolutely no comments as well. Thank you.
What was the IOL you used?
It was actually too wonderful to question her at all.
What was the IOL that was used? The intraocular lens.
That was a sensor IOL. That's generally the IOL which I like to put. Hydrophilic IOLs can opacify when you do a DMEC or a PDEK, so those have to be avoided when you're doing an endothelial keratoplasty because of the air tamponade. So what we generally use is the sensor IOL for various reasons. One is the material of the IOL, and also second, the 3-piece structure itself lends it to a lot of being able to do a lot of maneuvers. You can easily change Intrap while you're doing surgery and you have a problem. You can easily change to a glue dial. There's so much you can do when you have a 3-piece IOL as opposed to single. Sometimes then you would have to be forced to cut and explant and then do things. All of that is avoided.
Good. So thanks a lot, Susan, for being with us today here. So we look forward to you answering all the questions, the audience participation. So we go on to Dr.